I'd like to invite the next speaker, Dr. Yusuke OSHIMA from Osaka. He's a very renowned vitreoretinal surgeon, and he's come all the way from Japan to share with us his tips and tricks on the treatment of PVR in the MIVS era, retinectomy versus vitrectomy and buckle.
Thank you very much for the invitation to this marble meeting. So I'll give a talk about tips and tricks to treat the PVR. As you know, PVR is the most challenging complication related to the retinal detachment. Generally, it's reported as 7 to 8% of the primary retinal detachment surgery. So because of the recent trend toward to use the minimally invasive surgery, we preserve the conjunctival, so we have less chance to perform the buckle and trend to much higher chance for retinectomy. So, but there's still an unremained unmet question. It would be if the wide retinectomy can take over the role of the buccal combined procedure to treat the challenging PVR case. So right now we have so many useful tools to for the challenging case. Not only the wide angle viewing and channel elimination by manual technique, and so many dye we can stain the visualize the vitreals and the membrane, and also use the powerful carbon and silicone oil or gas for the terminate as a choice. So I showed some of the representative case here. And here is long-standing, but it's a primary PVR case. You can look at a very severe contraction around the equator. It's a very challenging case, but do you think you need to use the silicone oil for terminate when you combine the vitrectomy with the buccal? My answer for this case is no, because after removal of the membrane, you can use bimanual technique under channel elimination, and remove over the membrane around the equator. You can use powerful carbon to gently flatten the retina and make sure how it's a residual traction. So it's still some subretinal strand we need to remove. And you can see the very severe contraction pathology around the equator. But when you look at the peripheral area, the peripheral area, there are no any prominent contraction. And in most of the cases, I prefer perform the RM peeling underneath powerful carbon to remove scaffold to prevent the reproliferation. For this case, you know, the peripheral area is not so severe proliferation, so we just perform the wider retinectomy. We can flatten the retina. In this case, we no longer need to anything silicone oil. Simply use the long-acting gas, face the position. You can attach the retina with a single surgery. In this case, I still use a cryo to the peripheral area to make them a strong adhesion at the edge of the large retinectomy. In this case, I remove the lens and remain the AFIC style because we use a gas tamponade for one cavity, and after completely attach the retina, we can perform the second implantation. So this case, again, only the gas without any buccal can conclude the surgery. This is another case, sorry. This is a severe case with the silicone oil, the PVR underneath the silicone oil. In the minimally invasive surgical era, we no longer remove the silicone oil in the first procedure. We can let the residual silicone oil at the third hand to push back the retina. We only insert trocar under chandelier, use bimanual technique to remove the proliferation underneath the silicone oil. Silicone is very helpful at the third hand to push back the retina, so it's easy to let us to remove the membrane. After remove the membrane on the surface, we remove the silicone oil and they go to the back side of the retina, remove the subretinal membrane, and then again the fluid air exchange, and then use the refill with the silicone oil in the style. Again, this patient also we have the less traction and the proliferation of the periphery. So this case, I no longer need any buccal. Simply refill the eyeball with the silicone oil, you can attach the retina. This third case is complete with the anterior PVR. This case, you can see that most of the retina already attached, but it's a long-standing, very localized inferior attachment application complicated with iris neovascularization. This is the case, long-standing detachment, sometimes complete iris neovascularization have already reported by Professor Stanley Chang And after the HS regional, you can resolve the iris neovascularization characteristic in this case. Even though you have the iris neovascularization, you note any increased intraocular pressure. But you can see the case of very prominent residual membrane and the visual cortex remain around the far peripheral area. So encountering the very localized but very wide peripheral detachment, so the reason why leading to the long-standing detachment and causing the iris neovascularization. Again, this is the case with anterior PVR. In the first surgery, I tried to only remove all the membrane and use gas, the tamponade. I tried to HS region, but in the first surgery, I failed. Even we removed so many membrane, we use the scissors by mount technique, remove over it, and with the gas tamponade, but unfortunately, I cannot HS region completely. So finally, the second surgery, I need to perform a much wider buckle to support the peripheral area. The concept of the buckle is to make the new ola serrata to compensate the contraction of peripheral area. So in anterior PVR case, we have a higher chance still need to use the buckle as shown here. This last case shows it's very, very severe, very fragile, long-standing PVR after the first surgery by the other doctor for the epidermal membrane surgery. At the time, the visual acuity was 20/40, but after the severe PVR, the patient visual acuity reduced to the light perception. I showed the revision. It's very challenging because the retina is very ischemic and very fragile. Even the bimodal technique, the tangential peeling, still encounter some retinal breaks. As you know, this case, we cannot completely remove our membrane, so I still need to use the silicone or tamponade. But again, when you look at the peripheral area, it's not anterior PVR. So the main pathology is localized at the equator, so need to perform much wider, large retinectomy, followed by the complete membrane, try to remove the membrane as much as possible. Again, you can see a very wide retinectomy, almost a 70 degree retinectomy was performed in this case, but you need only to use any buckle if it doesn't work for the support serrata. In this case, I have a trade procedure. At the end of surgery, I performed powerful carbon silicone oil direct exchange. When we can HS retina, the visual acuity recovered to the 2100, but you can see a large area of the retinectomy was performed, so the patient still has concern about hypertony, so I still remained silicone with for a long time, and after remove the silicone 3 months after the initial surgery, so the visual acuity still remained at 2100. So in summary, I reviewed my positive case about over the 54 case. Unfortunately, because the small limited number of cases, there are no quite difference in the initial buckle or retinectomy. But when we look at the anterior PVR case, if we don't perform the big tracking, we don't perform the buckle on the initial surgery, have a higher chance of fail to HS retina. So my concept is if the anterior PVR still need to the buckle to support ola serrata. So in conclusion, the overall surgical outcome for PVR in the office-based surgery was totally tolerated. We actually had a higher chance to perform the retinectomy instead of combined between buckle for treating PVR case, but the initial case can reach into the 8 to 9%, not so bad. But still, when you think about the between buckle in the anterior PVR case. So further research is needed to evaluate compare different techniques in the management of the specific group in the patient and to highlight the crossover the recurrence. Thank you very much for your attention.
Thank you so much, Professor OSHIMA.